Transitions of care is maybe a new buzzword that you're all hearing, but in my 30-some years of practicing and taking care of older adults, especially in skilled nursing facilities and hospitals, this is really nothing new. So I'm going to go over some of the history, a little bit of some statistics, and at the end, show you a couple forms that maybe we can use and things to do that we can maybe counteract the miscommunication or lack of communication that exists because of electronic health records that we all have different ones that don't speak with each other. So hopefully we can improve movement of patients between healthcare locations and providers, improve communication of essential patient information to the next patient care setting, and improve medication reconciliation upon transfer from one prescriber to another, and hopefully foster reductions in hospital readmissions. I just want to give a disclaimer that's been on the prior presenter slides. I have it on my other presentation for this one, but we do receive financial support and backing from our geriatric HRSA grant at MSU. So that's my financial disclosure. So a definition of transition of care refers to the movement of patients between healthcare locations, providers, or different levels of care within the same location as their conditions and care needs change. So you may see this not just in the transfer of a patient from the hospital to a skilled nursing facility or subacute rehab, which I see all the time in our facility, but you may have a patient in a life care model living environment where they live in maybe assisted living, and then they go to skilled nursing, and then to a hospital. So it may occur in the same institutional environment, and there can still be lack of communication. So what it requires is actions to ensure coordination and continuity of care based on a comprehensive care plan, available well-trained practitioners who have information about the patient's treatment goals, preferences, and health status. Poor transitions lead to increased hospital readmissions, which Medicare and CMS does definitely not like. Can lead to duplication of services, medication errors, and lack of continuity of care from one practitioner to the other. Older adults are at particular risk. I'm a geriatrician, but it can also happen in younger patients, especially if they're more vulnerable and they need increased care. So they go from the acute hospital to a rehab unit. You know, it can be an effect on a patient of any age. But definitely those that have multiple medical problems, cognitive deficits, depression, isolated seniors, those living alone, non-English speaking patients, immigrants, and those with few financial assets. Transfers from nursing facilities. 8.5% of all Medicare admissions to acute care hospitals are made up of transfer of patients from the nursing facility. 40% of these hospitalizations occur within 90 days of admission of that patient to the nursing facility. 84% of these patients are discharged from the hospital back to that original setting. 1/5 of all Medicare patients are discharged from, that are discharged from the hospital are readmitted, usually within 30 days. And as a general observation, if you have a longer length of stay, then those patients are for sure more complicated, and they're going to need more of your attention. 90% of these readmissions are unplanned. It cost Medicare $17.4 billion in 2004. Now, there's a lot of, in the past 2 to 3 years, there's a lot of scrutiny by Medicare looking at hospital readmissions, and I'll mention a little bit about that, but those penalties can, affect your reimbursement. And readmissions within 30 days, ones that they're really looking at are heart failure, 26.9%, pneumonia, 20.9%, and they've also added recently chronic lung disease and bronchitis is diagnoses that they are paying attention to. So in analysis of post-acute and skilled nursing facility settings, 5 million patients over the age of 65 made more than 15 million transitions, and 1.1 million, or 22.4%, had subsequent healthcare use indicating a transition problem. Emergency department visits, hospital stays, or return to an institutional setting if they were discharged home. So if they get back to some other institutional environment, that's definitely a sign that there could be a transition problem. CMS in 2009 estimated 18% of Medicare patients are rehospitalized within 30 days of discharge, and 13% of those may be avoidable. Medication changes upon hospital admissions and discharge are a frequent cause of adverse events. I think we all kind of know that. How many of you practice in skilled nursing facilities? So a few of you. How many of you practice in a hospital setting? Okay, and the majority of you are probably in office space, right? Okay. So the medication changes that occur upon the patient's admission to the hospital can be brought about by all kinds of things. It could be, the patient's medical condition, obviously, but the other thing that kind of generates some of that change is hospital formularies. Well, here they're on, an ACE inhibitor, a certain one, let's say they're on lisinopril at home. They go into the hospital and then all they have is Ramipril. So it creates a dosage change, a change of a medication. And, same thing with ARBs and beta blockers and everything else. So you see where a patient goes from home to the hospital to the nursing home, and they all may have different formularies. And then it can, the patient says, well, here I have this new medicine, or what invariably happens when they come from the hospital to the nursing home, the nurse that is responsible for admitting the patient is trying to justify or reconcile the home meds, the hospital meds, and then the nursing home meds. And they, depending on their level of expertise and knowing about medications, well, they may say, oh, here, the patient needs to be on these 3 drugs. They may be all ACE inhibitors, and then they get initiated on the initial nursing home order. So it's a real exciting place to work, and you really have to know your meds and to reconcile all those meds. The one good thing is that we have consultant pharmacists that have to work in skilled nursing facilities. But again, they may not see that medication record immediately. So it's a major source of problem, the medication changes that occur. The patients regularly use medications are discontinued 46.4% of the time, and 38.6% are considered to have potential to cause moderate or severe discomfort or deterioration in their status at that point in time. 20% of patients discharged from a tertiary hospital experienced an adverse event on transition from the hospital to their home, and 66% were adverse medication events. 1/3 were considered preventable, and adverse drug events due to medication changes occurred in 20% of transfers between nursing homes and the hospital. So there's a high prevalence of medical errors when patients are transferred from the hospital directly to the community when they don't make that nursing facility stopover. Patients were 6 times more likely to be rehospitalized when the primary care physician did not follow up on workup recommendations by the inpatient provider. So communication deficiencies, and I have a stack of papers here, but you can imagine that, just imagine a ream of paper that you go buy at Office Depot or whatever. And invariably, that's the amount of paper we get often on a patient that's transferred from the acute care hospital to the nursing facility or subacute rehab. The EMRs, electronic health records, have not really made our job simple. Except for, I have one of our recent fellows in the audience there who sent us a patient a couple weeks ago, and we also got a fantastic discharge summary that was only about 3 pages. And I could tell exactly what happened with that patient. The medications were reconciled, but too often, and it doesn't matter what hospital or what electronic health record it is, we're getting disorganized sums of paper that we have to read through. I mean, hundreds of pages, and you can't tell. I had one patient that had a DVT, and I didn't find that in the record. It wasn't in the little, cut and paste summary that they put on there. I found that about 50 pages into all that ream of paper. So there are multiple problems, that can happen. And I'm not obviously the greatest fan of electronic health records right now because they don't communicate with each other. They don't communicate with us. So who's left to be responsible for the patient? All of us. So how can we make that better? Well, the hospital and primary care physicians rarely communicate directly with each other. Now, I go back 30-some years, we always communicated with people. We called them on the phone, say I have, often I did my own hospital admission, so that, took away the obstacle. But, we don't have that nowadays. There's, medicine has changed. We have hospitalists, we have nursing home specialists, we have the doc in the community. So we have to really find a way to communicate. So, as I mentioned, the hospital discharge summaries often did not identify who the responsible hospital physician was. There was no main diagnosis. There were no physical findings. Discharge meds were confusing. You can look at a discharge record. You can look at the medication reconciliation form from the hospital, and often they don't agree. Now, how does that happen? The follow-up care plans aren't specific or readily available. Other tests pending at discharge aren't identified. Counseling provided to the patient and or family may be missing or sparse. And 11% of discharge letters and 25% of discharge summaries never reach the patient's primary care physician. Only 25% of discharge summaries mentioned pending tests in the study by Weir, and that was from General Journal of General Internal Medicine in 2009. 13% documented all pending tests. 72% of pending test results requiring a treatment change were not mentioned in the discharge summaries. And only 67% of discharge summaries identified the healthcare providers responsible for the patient's follow-up care. Yearly, 25% of nursing home residents are transferred to the emergency department for evaluation, but 10% are transferred without any documentation. 90% of essential patient information is commonly missing. And especially those patients that are maybe discharged in the middle of the night, and you have your newest nurses working the night shift usually, and they don't have the experience. And so it's easy to see how that information can get lost in the shuffle. So practitioners fail to communicate the patient's care plan developed in one care setting to the next. So, what are the goals of care? What are the follow-up appointments and lab testing that are necessary? Review the current medication regimen and the requisite information about the care of the patient received. Breakdown of care processes. The preparation of the patient and caregiver can occur at any of those steps: the hospital, the nursing facility. They go from the nursing facility back home. Has there been a family care conference to discuss all of those plans and let them have input into the situation? What we do in our facility is every patient that's discharged after their therapy regimen, they usually get a home visit first, because you never know what kind of monster is residing at home. It could be stairs that they don't identify, or clutter, or all kinds of things that they don't think anything of it because they live in that environment for many years. So the home visit can be a major benefit, and our therapy staff will take the patient home before they go home to identify those potential problems. Transportation. It's come up in a couple presentations earlier. How do our patients get from one site to the next? If they get back home, well, can they drive? Did they have recent joint replacement surgery or a joint fracture, or have they had an amputation? And how are they going to get to their appointments? We really need to discuss that and identify how we're going to complete their follow-up care. What's the availability of diagnostic testing? So if they go home and we want follow-up on their INRs or their electrolytes or whatever, how are they going to get that test done? Is the visiting nurse going to do it? A lot of our hospitals in Lansing will do home draws on patients, so we don't have to worry about that. If you live in a rural area, you live in the UP, well, how is that going to happen? Do you have the visiting nurse staff that's going to, or the lab staff that's going to go out and do that test? When a patient comes from the hospital to the skilled nursing facility or subacute rehab, what can that receiving facility do? Can they perform the recommendations of follow-up? Can they do IV antibiotics? Can they check therapeutic levels on those antibiotics? If the facility or the lab can't do that, then that patient should not be in that setting, right? We have to make sure that all of those things that we recommended and identified in the care plan in the hospital can be followed through upon. And you've seen one nursing facility, you see one subacute rehab facility, you've only seen one facility. They all have different abilities. So you really need to be able to identify what your individual facility can do. And be able to identify and work with the patient on their advanced care directives across the settings, wherever they may end up. So, does the patient have the capacity to make medical decisions? Do they have a durable power of attorney for health care and someone that can help, facilitate those decisions as they get in these different healthcare environments? Many of the practitioners that are in hospitals now have never really worked in a nursing facility. Our patients historically look at nursing facilities as a place to die. So you go and tell them, we're going to send you to, we can come up with fancy names of places, and some of them will look like the Hyatt, but I don't care what the wall dressing looks like or the chandelier. Well, I do like to have at least some decent food in a facility, but I want to make sure that the staff can follow through on those medical orders. That's the most important thing to me. So I've seen many facilities that are I think make it easier for families to not feel guilty putting their relatives in a nursing facility. Well, that shouldn't be the main reason they go there. They should have a need for functional support of their activities of daily living, and be able to provide the medical needs. So, so that's part of our responsibility as the treating physician. But also, we need to educate all the docs, the surgeons, the orthopedic surgeons, and make sure they know what we can do. And if we can't do a certain thing, then we need to let them know we can't do that. Unfamiliar with care delivery capacity of these settings. So, so they may transfer those patients inappropriately, and that can be a real nightmare because the hospitals want to discharge the patient. They think that the patient has plateaued or stabilized, and we may not be able to cover them in the nursing facility. So other areas of segmentation, it's difficult defining what primary care comprises any longer. There's a dwindling supply of primary care physicians. Hospitals practice only within the hospital. They may be reluctant to write orders for patients moving into the community. Skilled nursing facility specialists, or SNFists. We are seeing more and more of that. I think you see more and more of it, especially if you're working with managed care, because they, in certain geographic locations, when I practiced in South Florida, if the patient had an established diagnosis and a treatment plan identified, and that was done in the ER, they would often be admitted directly to a skilled nursing facility rather than the hospital. So they never were actually seen except by maybe the emergency room physician, and then those docs in the nursing home had the responsibility of following up on the care. So that can vary according to whatever community you go to, or it may be in our future here. So, I look at my role, my primary role is the patient advocate. So all of us have to be the voice for our patients. So we have to make sure that we always are able to, yes, we want to deliver the care in the most cost-efficient manner, but we have to make sure we're delivering the appropriate care. So community physicians are often asked to resume the care, approve multiple services and prescriptions, and may have little knowledge of the illness episode or the follow-up visit to approve services, medications, or treatment. So, we all have to, make sure that we're communicating, that we can have an open line to the physician in the hospital and talk about what's going on. I feel comfortable, talking to my hospital staff, physicians, and figuring out what the patient needs. Treatment may be delayed with a gap during which no practitioner is actually overseeing the care of that patient. So that there can be a discontinuity of care from the hospital to the nursing facility to the home to even hospice. And it can take 24 to 48 hours at times to obtain pain medication prescriptions, as Dr. Karen identified. So, we need to be certain that our patients are receiving all the necessary medications, including pain medications. So what are some of the barriers? Well, medical care is existing in silos even more so than ever before. Each care setting functions independently without formal relationships. Information systems may be incompatible with each other. We have 2 hospitals in Lansing. They have 2 different electronic medical record systems. If you're on staff at one of them or both of them, okay, that's going to be helpful. But, the nursing facility is starting another electronic medical record that I work at. And every other nursing facility in town has their own electronic medical record. We really created a hell of a system.
The government, we did.
Well, that's true. Well, I'm speaking collectively. But we all know those aspects. Financial incentives may be lacking. Multiple formularies. Every place that patient goes has a different formulary. Every insurance company has a different formulary. Prior authorizations and the like can be major problems. Constant medication switches when the patient goes from one site to the other. Generic substitutions that, patients and nursing staff and even physicians may not be aware of all the different names of medications. So each hospitalization can result in a different patient drug regimen. And that's one of my greatest challenges. And insurance coverage can drive the service delivery. And in some places that I've practiced, that actually has resulted in the change in the primary care physician if they change their insurance coverage. A single clinician rarely provides continuous care for a patient across care settings any longer. It used to be. I used to do that. That was my usual way to practice. I'd go stop at the nursing facility at 6 in the morning. I'd go make my hospital rounds, then go to the office. Maybe have to stop back to the hospital, even a couple times during the day. Well, that supposedly was inefficient and created poor care. But we have another set of problems with having specific physicians in each care setting. So clinicians in different care settings don't communicate information to one another, at least not as maybe appropriately as we should. Multiple consults with multiple specialists, multiple additional tests, multiple medications. Many may be unnecessary. So that may generate multiple follow-up appointments and tests. Now, care managers and social workers can be an important asset to our care to try to identify these needs of the patient. And I'm working with them all the time. The one difficulty is often, though, that even they don't work across care settings. They still have to talk to their mirror image at the hospital as an example for the care manager or the admissions staff. They presume that the healthcare professional will take care of their needs. You know, that's our patient's belief. They're not informed of their disease process appropriately and the next steps and the next setting that may come down the road. They may not be empowered to express their preferences of care or provide input to the patient care plan, either the patient input or the family. And take-home information may be conflicting and result in confusion. We may have cultural barriers, different expectations to the treatment plan. Language fluency may be an obstacle. And just healthcare literacy in general and how to accomplish things is very common. Cognitive impairment is something that I deal with every day, and how patients and their families still want to live at home even with significant decline in memory, and they may not be able to carry through on that treatment plan or get confused with all of the medications. I have patients that, you know, use the pill box method. So they'll have a pill box with, you know, 7 days of the week and maybe 4 slots for 4 dosings per day. And, you know, but they still have that pill bottle sitting there. And I've had patients that they take their pills on a certain day, the appropriate day. Well, then they come back later that day and say, oh, I got to fill my pill box. So they put the pills in there again. So someone has to be responsible for medication administration. And that often is a major obstacle because families are trying to keep their loved ones at home independent and also, you know, stay away from the high cost of nursing facility care or assisted living. Advanced care directives, they need to be discussed in advance with the primary care physician. So everybody kind of has an outline on what to expect and what to go for. We need care coordination of discharge services, arrange follow-up appointments. We need to reconcile medications and educate our patients. And often in a busy physician practice, that's very difficult for us to do. So we need help in doing that. But that care coordination has reduced emergency department visits and readmissions within 30 days of discharge by 30%. So we know it can be done, but you know, we need to identify who can help us, you know, in your own individual community. The Care Transitions Intervention, which was published in the Archives of Internal Medicine in 2006. So, you know, these are not new things. I mean, this is almost 10 years ago. You know, we've studied this long enough. They identified a transition coach that could provide that continuity of care across the settings and be accountable for that. They ensured the patient's needs were met regardless of the setting that they were in. It reduced hospital rehospitalization rates as far as 6 months out in population of chronically ill community-dwelling older adults that were over the age of 65. The 4 factors most valuable to the patients and caregivers were assistance with medication self-management, and, you know, but you got to be honest. Everybody's got to be honest when they assess that and make sure that, yeah, the patient can do that, or there's someone there that can make sure the medications are really delivered timely and appropriately. Patient-centered record owned by the patient to facilitate cross-site information transfer. So, you know, we have an electronic health record at Michigan State. So at the end of that visit, we always print off their diagnoses, the reason for the visit, their medication list, any follow-up tests are listed on there, and their follow-up appointment. So, we need to be able to give our patients something that they can take to whoever, and they can read it, and say, oh, here, I do have this appointment coming up. Arrange timely follow-up with primary or specialty care, and a list of red flags indicative of a worsening condition and instructions on how to follow them. So we do need to let them know what can change and what may be deleterious and how they can follow up with us. At MSU, we have the Michigan Primary Care Transformation Program, which is a CMS program, funded program. Our MSU nurse care manager and social worker will see the patient, follow up on making sure that they're getting the appointments done. And it's something that, they are interacting with me on a daily basis at least. And we can just see what kind of problems are developing in our patient. We get notified if, they have to go to the ER or are admitted to the hospital. So, these kind of programs can help strengthen the patient care team relationship. There's no cost to the patient for this program, and in the primary care doc is in the center of the care. The other benefit is that it helps patients manage their own care needs. How can we conduct care transitions smoothly? Essential patient information has to be transmitted to the next care setting. And it doesn't matter how much the papers weigh. It can just be 2 or 3 pages. We need to find an effective way of accomplishing that. We need to be responding to our hospital systems and say, this EMR is not accomplishing what we need. If the old-time dictated discharge summary, or, get on there and type a discharge summary like you would, if that will affect a positive change, then we need to accomplish that. Healthcare professionals involved in the care of the patient need to communicate appropriately about the patient care needs. So if there's something that you really think is important, whether you're sending the patient to the emergency department or you're the hospitalist and sending that patient back to primary care or to a nursing facility, get on the phone and talk to that doctor. Probably will take you 2 minutes. But that can be the thing that I think is really missing. And remember that this is a transition of the patient from one setting to the other. It's not discharge of the patient. Like we know that hospitalists or the doc in the hospital, the specialist, the orthopedic surgeon, it's not that they're not going to see that patient ever again. I'm discharging you from my care. It's a transition from one setting to the other. They're still involved. They need to think about that. So it's not discharge, which implies that the patient is no longer our responsibility, because that contributes to the lack of continuity of care. It actually extends our provision of medical care to that next level. So everybody is accountable for this. Assign a designated person with each care site for every transition task. Individual accountability for a specific task, but safe transitions are really everyone's responsibility. So whether they're the admission nurse, at our facility, we have an admission nurse for each unit, and they follow that patient that whole stay. They look at what's going to happen, discharge planning, what level of care are they going to go to after? Are they going to be able to go back home and be independent even? So that that's our accountable person. We also have the social workers involved. We have a social worker on each unit. So, you know, they really know their patients, they know the families. We have family care conferences on a regular basis. So the relationship needs to be centered care, focused on the patient and the family, and you know, or whoever that patient support system is. And we need to respect the patient's autonomy with privacy, you know, HIPAA regulations, and but negotiate that in the patient's best interest. So develop relationships with the counterparts. So the social workers at the nursing facility need to communicate and be able to work with those same people in the hospital and home health agencies and other community service agencies such as dialysis centers and infusion therapy centers. Review writing orders. And that's something that we're doing, you know, that's one of my most important jobs that I do. I'm looking at all those orders, and I want to look at, you know, what that admitting nurse is thinking, okay? Well, I may be the one that has to identify that, well, they're on 2 ACE inhibitors, or they're not on DVT prophylaxis after a joint replacement or whatever. You know, that's where we need to be held accountable for that. Make sure the patient and or the family has records so they can take to that next setting, and you know, find out ways on how to contact the patient's family and arrange transportation. So we need training at all levels of care and all the sites. So our hospital-based physicians know that certain services may not be available in the long-term care setting. They may not have 24-hour diagnostic services such as, you know, getting therapeutic drug levels and things like that. And they need to know that physicians may not be available at those sites at all times. We need to train the caregiver and include them in the care conferences so they know what they can do, and we need to assess what the caregiver can do. Some caregivers can do everything like treating pressure ulcers and administer IV antibiotics, and others can't even put on a Band-Aid. So, you know, you need to assess what that caregiver can do. Create the most current list of medications and compare that against orders from the other settings. 66% of reconciliation errors occurred during transition to another level of care. And like I said, each facility may use a unique formulary, and you need to know that, and there may be unintended drug admissions. So that's a safety goal from the Joint National Commission, and also a CMS guideline for nursing facilities. All skilled nursing facilities have a requirement to have a consultant pharmacist, bring them in on that decision making. And be aware of also over-the-counter and complementary medicines, vitamins, supplements, and any drug allergies a patient may have. Also be aware of any non-prescription drug use and things that they get over the counter, their sleepers, all the, you know, Tylenol and Advil PM and other agents they may be taking over the counter. Hopefully, in the near future, we'll find a method that our electronic health records can share information to where they're easy, interoperable, and secure. I think it's possible, but I don't know. It may not be in my practice lifetime. So that's when I have to pick up the ball as the attending physician. Financial issues. 1/5 of Medicare patients discharged from the hospital are rehospitalized within 30 days. You know, their CMS definitely has a financial incentive or disincentive for hospitals if these patients are readmitted within 30 days, especially heart failure, heart attack, and pneumonia. And I mentioned the emphysema and bronchitis. So, yeah, care transitions. Many of these transitions may be, you know, they can be planned or unplanned. But when we recognize that there's a status change in the patient, we have to act on it. Anticipated, obviously, those patients that are post-surgical and a need for rehab. But unanticipated examples are those patients that fall at home or in a nursing facility. So a system should be in place for the caregiver to communicate that status change. Whoever the caregiver in a skilled nursing facility obviously is the nurse. If there's a status change, they have a responsibility to notify the physician, the attending physician, you know, when that occurs, not the next morning or if it's on a weekend on Monday. That has to be the attending physician or the covering physician needs to be notified of that status change. So how do we implement this? I think having interdisciplinary team members communicate with each other is important. Bring in the patient and the family caregiver. And the transition should be guided, however, by the advanced directives of the patient. That's something that we need to work on, getting that identified in every one of our patients. And the sending facility should communicate that with the receiving entity. So patient information should be received prior to the arrival of the patient, and oral communication is ideal. Now, I know you can't see these forms, but you can, they're from the American Medical Directors Association Clinical Practice Guideline on Transitions and Care. You can utilize these forms to maybe make up your own forms. They allow that. But things, as an example, that that are on the form are the patient's name, their date of birth, their admission and discharge date, their admitting diagnosis, diagnoses from prior admissions, any surgical procedures that were done, laboratory studies, results of pertinent tests such as x-rays, EKGs, MRIs, CTs, any allergies to medication, the admission weight and the discharge weight, their advanced directives. Do they want CPR? Do they want artificial nutrition? Do they want further hospitalization? Has the patient had a recent fall? And then comment on the hospital course. That's that center section here. So, you know, you can hand write that. I mean, I can probably hand write something on 10 lines that's going to tell you exactly what happened to that patient in the hospital. Is the patient aware of their diagnosis, yes or no? So you can review these forms and you can see how, you know, it also asks for the medications that that patient should be on at discharge. So, you know, often we can get that on an electronic record, but there has to be the same information has to be on the discharge record in what the patient was on receiving in the hospital. We have to know if there isn't coordination or compliance in that regard. We need to know why that was changed. So, and this is an example of a transfer form from the nursing facility to the hospital. So all the appropriate information on what their diagnosis is, their attending physician, have they had things like pressure ulcers, speech problems, what's their mental status, what's their transfer, activities of daily living status, and then a copy of the medication administration record. So it gives the information on what exists in that patient at the time of the transfer.